Hello, everyone, and welcome to the September Surgery Symposium here at New York City Health and Hospitals at Kings County. Today, we will be covering the discipline of breast surgery. Slides up, please. So my name is Dr. Jaime Alberty, and I am the director of the Division of Breast Surgery here at Kings County and of the newly formed Comprehensive Breast Center. I joined Kings County back in December, so coming up on a year. And so my role here has been to bring cancer care forward and breast cancer care forward at our institution. Nowadays, it's important to know that breast cancer is thought of as a multidisciplinary disease. And so with that goal in mind, we have created the Comprehensive Breast Center. At the tail end of the talk, I'll sort of brief you guys on the work we have been doing at the Comprehensive Breast Center. We've been working very, very hard and are very, very proud of what we have accomplished so far. Next slide. So when I was asked to speak on how breast surgery has evolved through the years, I thought it best to sort of divide it into three areas. First, I will speak on how the discipline of breast surgery itself has evolved and changed through the years, and this sort of centers around the concept of de-escalation, which pretty much just means doing less, right, to arrive or achieve the same or hopefully even better results. We'll discuss just a little bit of the most seminal data, let's say, not going into too much detail, but I do want people to sort of understand the reasons, the scientific reasons behind why we reach the medical decisions that we reach. Also, we'll talk about new technologies that we have adopted here at Kings County Hospital and how, adopting those have helped us improve the quality of patient care during the past year. And finally, I will do a little plug and introduce the Comprehensive Breast Center, which opened back in May of this year and has been doing very well. A lot of exciting things down the pipeline. Next slide. So just to start, obviously everybody knows about breast cancer. Everybody knows somebody who has had breast cancer. If we talk about the statistics, the general statistics of breast cancer, the incidence of the disease continues to be 1 in 8. So 13% of women will be diagnosed at some point with breast cancer, which is quite a large portion of the female population, right? It is a very prevalent disease. So if we look at the estimates for 2021 from the American Cancer Society here in the United States, it is estimated that over 330,000 new cases of breast cancer will be diagnosed, both invasive and in situ disease, and that is in women. Obviously, something very important for us to remember is that us men, right, we also get breast cancer as well, even though it's much rarer than in women, only 1% of those cases, but it is estimated that over 2,500 men will get breast cancer this year. Here in New York State, estimated that 16,000 women will be diagnosed every year. And it's important for us to understand that breast cancer is indeed the second leading cause of death, but that mortality has been steadily decreasing since the 1990s. And that has a lot to do with early detection, better imaging studies that we do, better treatments, especially systemic treatments. Chemotherapy has improved quite a lot. And then improved public awareness of the disease, ways for us to diagnose it early and treat it effectively. Next slide. Previous slide, please. Okay. Next slide. Next slide. There we go. Okay. So to start, when we talk about the evolution of breast surgery and how breast surgery and the discipline has evolved through the years, it can be summarized by the word de-escalation, right? De-escalation is a concept that refers to the idea of doing less to achieve equal or hopefully even better results. And we have seen this not only with breast surgery. Like I said, breast cancer is a discipline that requires more than one discipline, right? We have also seen it with medical oncology, with genomics, with genetics, with radiation. For us in surgery, however, what we offer today is very different from what we offered before. On the left, you will see, on my left, you will see pictures of patients that received radical mastectomies, which was the surgical standard of care for many, many years for patients with breast cancer. And through the years, we've figured out ways of arriving at the same oncologic result, i.e., removing cancer, making sure that patients are alive and well through different operations that we are able to access the breast in order for quality of life to improve and for patients to have a better understanding of their disease. Next slide. So we're going to go a little bit into the nitty-gritty of breast surgery. Everything started with the radical mastectomy back in the 1890s. Dr. Halstead from Johns Hopkins described the first radical mastectomy, which then became the gold standard to treat breast cancer for the next 75 years. It was a big, big operation. We removed all of the breast tissue, the skin, the muscle, so it was a little bit deforming. And so for many, many years, we started to sort of think, how can we arrive at the same results without something that is so deforming? The concept of more conservative surgery soon followed, and obviously that's what has defined the discipline of breast cancer through the years. Next slide. Basically, one of the groundbreaking seminal studies in our discipline was the NSABP, or National Surgical Adjuvant Breast and Bowel Project study called B04, which next, it's two pictures right here, which basically the goal of the study was how can we arrive from the left, right, a radical mastectomy into something that's more cosmetically pleasing while still being oncologically safe. Next. So again, we're not going to go through all of the data, but basically it's a study, big study, accrued patients during the 1970s, reported later on. It found 3 groups of patients that underwent either radical mastectomy or total mastectomy, i.e. Not removing the pectoral musculature, with or without an axillary dissection, and with or without radiation therapy. Next slide. And basically in terms of results, what they found was that there was no difference in survival, whether that was overall survival or disease-free survival between all of the groups. What this led us to sort of decide, next slide, this opened up the door for us performing less aggressive mastectomies. And obviously, you know, this has changed a lot through the years. I thought it would be a good idea for us to sort of review the nomenclature of mastectomy. Like I said, radical mastectomy, the original mastectomy, very extensive surgery, rarely done nowadays. I'm sure our residents haven't really even seen one. Involves excision of all the breast tissue, the skin, all of the axillary nodes, and the pectoral musculature. This sort of went out of, or sort of what we are doing, into the simple mastectomy, which is removal of the entire breast, including the nipple and the areolar complex. When we started doing immediate reconstruction of the breast tissue, we decided to leave behind most of the skin envelope. And so that's when the skin-sparing mastectomy, which we still use, perform pretty often nowadays, when we perform mastectomies in conjunction with our plastic surgery colleagues. The modified radical mastectomy is a surgery in which we remove all of the breast tissue and all of the lymph nodes, so that is something that we still perform nowadays. And then the newest iteration is the nipple-sparing mastectomy, sometimes called the nipple and the areolar sparing mastectomy, which, like I said, is a variation of the skin-sparing mastectomy, leaves behind the nipple and the areolar complex. Next slide. I'm going to talk a little bit more about the nipple-sparing mastectomy. It's, again, the newest iteration of the mastectomy operation. Next slide. It requires preservation of the entire skin complex. There's a different incisions or approaches that we can take to this. Most of the time, it is done through an inframammary approach. So at the end of the day, we hide the scar. So a patient, again, doesn't even need to see her scar down the line. The operation has the potential to dramatically improve cosmetic outcomes and quality of life for the patients. And during the last 20 years, when this operation has sort of gained favor, the oncologic safety of the operation has been really encouraged by retrospective studies. Obviously, surgeons were a little bit sort of hesitant to do this operation in the beginning, especially for cancer patients, but nowadays we know that it's completely safe. Main indications for the operation, sort of 2 buckets, one being prophylactic surgery. These are patients that don't have cancer, but are, however, at high risk of developing cancer. Genetic testing is a field that has evolved a lot during the past 20 years, and so nowadays we're casting a wider net in terms of the patients that we genetically test. And again, we're finding more and more patients with predisposing genetic mutations for breast cancer. Another thing that we have to consider is that just more patients are asking for this operation. A couple of years ago, and the actress Angelina Jolie went public with her diagnosis of BRCA1 mutation, and she underwent a nipple-sparing prophylactic mastectomy. And so obviously after this happened, a lot of patients have been asking for this. The other bucket for the nipple-sparing mastectomy would be the therapeutic or for cancer treatment. It is in the NCCN guidelines, again, for carefully selected patients within multidisciplinary settings, which again is what we are trying to build here at Kings County with the Comprehensive Breast Center. Next slide. Like I said, the nipple-sparing mastectomy is within the NCCN guidelines, National Comprehensive Cancer Network. And they stipulate that it is an option for carefully selected patients, again, within a multidisciplinary setting. There is robust retrospective data for its use in early stage breast cancer, DCIS or in situ carcinoma, and obviously for risk reducing procedures. The important surgical tenet here is that we need to make sure that we assess the nipple margin that we leave behind in the breast so that we don't leave any cancer behind. Next slide. So again, these are guidelines and these are sort of softened through the years, but the ideal candidate that would be a candidate for nipple-sparing mastectomy would be a woman with small breasts without any ptosis or hanging of the breast, that has a low BMI and is not actively smoking. Obviously, not all patient is ideal, right? And so there are ways that we can sort of work with the higher risk candidates while always trying to avoid surgical complications. Next slide. In terms of what patients think, patients obviously are very satisfied. Quality of life is improved from the baseline, which was the radical mastectomy, and then the total mastectomy with or without reconstruction. That being said, it is not a perfect operation. There are factors associated with decreased satisfaction, patients that are increased BMI, that need post-mastectomy radiation therapy, patients that are actively smoking. So overall, it is a surgery that is still considered young. We have a lot robust data behind it, so we feel pretty comfortable performing it both in the prophylactic and the therapeutic setting. Next slide. So moving a little bit away from mastectomy, the other big operation that we perform would be lumpectomy. And through the years, we wondered if less radical mastectomy was not inferior to the Helstedian procedure, right? Could we get away with even less surgery? Next and next. So again, going from the left to the right, where you are able to preserve a woman's breast with a small scar while still performing an adequate oncologic operation. Next slide. In terms of the evolution of breast surgery, breast conserving surgery, again, or lumpectomy, a number of randomized control trials came out. Next slide. I'm going to just briefly talk about the two most often quoted ones, one being the Milan trial from Italy from Dr. Veronesi, which compared radical mastectomy patients to quadrantectomy. Basically, they defined a lumpectomy as just removing one of the 4 quadrants of the breast, and then these patients would be followed by radiation therapy. And again, not to go into all the data, but they did not find any significant difference between both groups in terms of overall survival or breast cancer specific survival. There was a little bit more higher local recurrence that was seen in the breast conserving group, which commonsensically, right, if the breast is still there, it would assume that cancer would recur a little bit higher, but this does not affect survival at all. Next slide. Here in the United States, the study was the NSABP B06, which again compared 3 categories of patients. One's receiving total mastectomy, one's receiving a lumpectomy only, and then one's receiving a lumpectomy and radiation therapy after. Next slide. And in terms of the data, we did not find any significant difference or significant difference in terms of disease-free survival or overall survival between the 3 groups. In terms of recurrence, yes, we saw a difference between patients that received lumpectomy only and patients that received lumpectomy followed by radiation therapy. And this is the data that we use nowadays to almost always recommend radiation therapy after a lumpectomy. Next slide. So in conclusion from this study, that was published over 20 years ago, we found that in comparison with mastectomy, breast conservation or breast lumpectomy was appropriate therapy as long as it was followed by radiation therapy, provided that A, the margins were free of cancer, obviously, and that B, the patient had an acceptable cosmetic result after the surgery. Next slide. When we started doing lumpectomy many years ago, there were obvious contraindications to the procedure, which again, through the years have softened. Patients who have had previous radiation to the breast, patients with multiple areas of cancer in the breast, patients that presented with high or large sized tumors, large tumor to breast ratio, meaning a small breast with a large tumor, and patients that are pregnant and would require radiation therapy before delivery. So like I said, all of these sort of quote unquote contraindications have slowly but surely softened through the years. This is an operation, next slide, that we perform a lot. We know a lot about. There's a lot of very robust data around it. And nowadays, we have also thought about ways of accessing these cancers through different incisions, through different ways, so that, again, we increase the cosmetic outcome of the patient. Important for us to know that surgical margins, or the borders of the piece of tissue that we remove, are important for us to discuss with our pathology colleagues. And then there's ways that we have in the operating room to try and reduce margins being positive after we perform a lumpectomy. And I'll talk a little bit about ways that we are doing that here at Kings County. Next slide. So in terms of how much can we cosmetically get away with while still performing oncologically or cancer safe operations, next slide, the concept of oncoplastic breast surgery came around. Oncoplastic, like the word says it, right, it's cancer and plastic or reconstructive surgery put together. Refers to the application of plastic surgical techniques to the principles of breast surgical oncology. There's many widely used techniques that we use nowadays in terms of incision placement, tissue rearrangement, breast reduction or contralateral balancing procedures in conjunction with our plastic surgery colleagues. Important for us to know, and for us as breast surgeons to know, that we have the potential to use one or many of these techniques in almost all patients that we see. Next slide. Like I said, a variety of options or techniques that we can apply to each and every patient. We are fortunate enough here at Kings County to have a set of lighted retractors, which are quite useful in these cases. Help us, again, remove cancers, perform oncologically safe operations while having great cosmetic results. Next slide. When we talk about oncoplastic techniques, there's 3 levels of surgeries that we perform, and they have to do with the amount of breast tissue that we remove. Oncoplastic breast procedures levels 1 and 2 usually are performed by the breast surgeon by themselves, and then levels 3 is when more than 50%, I apologize, of the breast tissue needs to be removed, and usually we perform these operations in conjunction with the plastic surgeons. Next slide. So again, we are trying to change how we approach lumpectomies by offering patients the same oncologic outcomes through different approaches. So when we talk about incision placement or things that we can do to hide scars, right? When we talk about cancers that are in the upper pole of the breast, we usually consider going in through the areola, which is a dark part of the nipple, which can be used to access cancers or lesions in either the outer or the inner quadrant in the upper pole of the breast. Next slide. When we talk about the lower pole of the breast, we sometimes can go in through the inframammary area, right? Hide a scar in the inframammary fold, and that way the patient won't even see a scar in her breast. Next slide. When we talk about cancers, next slide, please. Next slide. Next slide. Next slide. And next slide. There we go. When we talk about cancers that are closer to the axilla, we can also consider the axillary approach, which would require a single incision in the axillary tail that would allow us to remove both the cancer in the breast and the sentinel lymph nodes in the axilla. Next slide. Next slide. Next slide. There we go. Again, other iterations of oncoplastic breast surgery that we perform. Some patients sometimes require a small lift, and they have a small central cancer. We can perform a bat wing mastopexy, which involves a perialveolar incision with an extension laterally and medially for us to be able to access the cancer and do a small lift at the same time. Next slide. When we talk about, again, central lesions in a mildly ptotic or hanging breast, we talk about the round block technique, in which basically the patient would benefit from a slight lift through a circumalveolar incision with a little bit of de-epithelialization, in which the two incisions would then be closed using a running or non-absorbable suture. Next slide. And then when we talk about larger, the need to remove larger amounts of tissue, we usually may perform surgeries in combination with our plastic surgery colleagues, and patients may get reduction mammoplasties at the time of lumpectomy. Next slide. So shifting gears a little bit, when we talk about mastectomy, lumpectomy, we usually always consider surgery in the axilla. In the same vein that we always try to de-escalate the surgery that we performed, we also wondered, is there a way for us to de-escalate what we do in the axilla? Lymphedema is a surgical complication or a side effect of performing surgery in the axilla, which is very deforming. And so we're trying to find ways for us to avoid this happening to patients. Next slide. Historically, for breast cancer patients, we would perform axillary lymph node dissections, which is an operation that would require the removal of all lymph node tissue under the arm. And one of the things that we found was that the majority of breast cancer patients did not actually have pathologic disease in their axilla. And so we were effectively removing healthy tissue that the patient could retain in their bodies, right? Next slide. This is when the sentinel node biopsy came along. Sentinel node biopsy is an operation that has been out there since the early 1990s. The idea with the sentinel node biopsy, which we have been performing for many, many years now, is that if the lymph nodes in a woman's axilla are sort of in a branch pattern or chain, by us finding the first couple lymph nodes in that chain, excising them and removing them and testing them, if there is no cancer there, then there should be no spread or metastatic spread of the disease beyond the axillary lymph nodes. This is a procedure that has been widely validated using randomized controlled trials, and they compare them to the axillary lymph node dissection. And again, next slide, it has become sort of a very safe and well-tolerated procedure. Nowadays, we use both a radioactive dye and a blue dye, and the use of these are very, very safe. In terms of the lymphedema risk that we are so trying to avoid, the risk is much lower than with an axillary lymph node dissection. And the early NSABP trials quoted the risk of lymphedema to be in the single digits with sentinel node biopsy and as high as 15 to 20% with an axillary dissection. So again, we're trying to avoid comorbidities that we don't need to have. Next slide. There are contraindications to the sentinel node biopsy for patients that present with a clinically positive axilla, patients that have inflammatory breast cancer. And then there are softer contraindications that, again, have softened through the years. Patients that are pregnant, patients that have ductal carcinoma in situ, or patients that have had cancer before and have cancer recurred or come back. And these are settings in which we now can safely perform sentinel node biopsy. Next slide. So again, in the concept of de-escalation, knowing that the sentinel node biopsy is a safe and accurate procedure for patients that present without cancer in their nodes, we wondered, could we do this for patients that present with cancer in their lymph nodes? Next slide. And this is where the big study, ACOSOG Z11, came out. It was published in 2010, 2011. And the objective of the study was to determine if the sentinel node biopsy procedure alone would provide similar control of the breast cancer and survival as well as the previously used axillary lymph node dissection. Basically, one group received just a sentinel node biopsy and one group received sentinel node biopsy followed by axillary dissection in patients that had 1 or 2 positive nodes. And what they found was that there was no overall difference between both groups. The results, next slide, do not apply to, again, mastectomy patients or tumors that were really large. Patients have had neoadjuvant or surgery, chemotherapy before surgery, or patients that have had 3 or more positive nodes. Next slide. And then the 10-year update, which was published in 2017 in JAMA, at a median follow-up of 9.3 years, again, there was no significant difference in overall survival or disease-free survival between both groups. So again, this is an operation. Next slide. We can see the data here, the lines, again, showing no significant difference between both. Next slide. The ACOSOC Z11 is a study that pretty much changed how we access or address the axilla in breast surgery, and it made itself all the way up to the NCCN guidelines. Big impact from this study. Next slide. So how has this study changed the way that we perform sentinel lymph node biopsy since the study was published? And obviously here at Kings County, we no longer perform routine frozen sections on lumpectomy patients, provided that the patients meet the trial criteria. Next slide. You know, nowadays, a lot of patients are receiving what we call preoperative or neoadjuvant systemic therapy, which means getting chemotherapy or endocrine therapy in their body before they proceed with surgery. Now, the question, obviously, in terms of de-escalation was, is sentinel node biopsy safe and accurate in this population? Next slide. So things that we know are that for patients that present with clinically node positive, right, cancer in their lymph nodes, advances in systemic therapy or chemotherapy have allowed us to, quote unquote, downstage those patients. That means the lymph nodes and the axilla that were usually or presented with cancer with systemic chemotherapy may be downstaged into no longer having chemotherapy, right? So the question is, should we still be removing all of the lymph nodes on these patients? So next slide. In order for us to answer these questions, 3 big studies came out, one in the United States called Z1071, one in Europe, and one in Canada, which aimed to compare sentinel nodes both in the patients that had positive lymph nodes. In terms of conclusions of the studies, we found that the sentinel node biopsy was a completely acceptable and safe operation to use in this population. Next slide. And again, the goal when we approach patients that have node positive disease is to optimize the surgical technique that we use nowadays. And in order for us to do that, we use, like I said, dual tracer, both the radioisotope and the blue dye. We should be looking at increasing the number of lymph nodes that are excised. And nowadays we perform something that we are performing here at Kings County, which is a targeted axillary dissection, which means when a patient presents with their cancer originally and the lymph node is biopsied showing metastatic disease, we are then able to clip and target that node and extract that node at the time of surgery so that we are able to pathologically evaluate that node at the time of surgery. Next slide. In summary, in terms of the axillary management of these patients, for patients that present with lymph node negative disease, we can safely perform sentinel node biopsy after neoadjuvant chemotherapy. And for patients that perform with lymph node positive disease at presentation, we will work up and image the axilla, biopsy and clip any suspicious nodes. And after the systemic therapy, we can perform an optimized sentinel node biopsy. When the lymph nodes are negative, no further surgery is needed. And if there is any lymph node that is positive, then we would perform a completion axillary dissection. Next slide. Next slide. So again, these guidelines have made their way all the way up to the National Comprehensive Cancer Network, and who offer the option of de-escalation while acknowledging that axillary lymph node dissection is still the gold standard. Next slide. And again, the American Society of Breast Surgeons, you can go on their website and see that we are using these sort of surgical tenets for us to be able to stage patients' axilla. Next slide. So again, that's sort of the data part of the talk. I'm going to talk a little bit about the new technologies here at Kings County and how we have been able to advance breast cancer care during the past couple of years. Next slide. I'll talk a little bit about breast imaging and sort of the advances in breast imaging that we are offering patients here at Kings County nowadays. Same thing with localization procedures and margin assessment in the setting of lumpectomy. Next slide. So in terms of breast imaging, the breast imaging division under the direction of Dr. Nisha Patel has brought in a number of advancements for patients for us to be able to better screen and detect breast cancer. Breast tomosynthesis is one of them, digital mammography, breast sonography, magnetic resonance imaging, and then obviously image-guided percutaneous biopsies, which here in this hospital, they're performed under stereotactic or mammographic guidance, ultrasound guidance, and MRI guidance as well. When we talk about a 3D mammography, a lot of patients may ask you about breast tomosynthesis. And basically, a tomo, as we call it, is an advanced form of mammography, which uses low-dose X-rays and computer reconstructions to create 3D images of the breast in order for us to sort of overcome some of the limitations of digital and obviously the older analog mammograms. There's multiple images of each breast from differential angles, which are then synthesized into 3D images. I like to explain it to patients like it's sort of like a CAT scan of the breast, where a radiologist is able to in real time scroll through the breast and see any tissue that may be overlapping or hiding behind other breast tissue. There is a slightly higher radiation dose, but this still remains within the FDA approved safe levels for mammography and is a very safe screening or imaging procedure to perform. This was introduced here at Kings County in 2020. In terms of breast MRI, again introduced last year as well. It is an imaging test that uses magnetic fields and radio waves to detect breast cancer and other abnormalities in the breast. And nowadays we're using it for patients that already have cancer in order for us to determine the extent of their disease, and also to screen patients that are at high risk of developing breast cancer in the future. There are other clinical indications, and it's nice to know that we can offer this to our patients here at Kings County nowadays. Next slide. When we talk about breast conserving surgery or lumpectomy that I spoke about earlier, there are certain lesions in the breast that we consider not to be quote unquote palpable, right? That it would be hard for the surgeon to find without some sort of guidance or target. And through the years, we've used wires for us to be able to guide the surgeons to these lesions in order for us to remove them adequately and safely. Wires, sometimes used with needles, have been sort of not the favorite thing of patients through the years. And so we have tried to come up with new technology, whether they're seeds, intraoperative ultrasound, or other technologies that we have tried to introduce into our discipline so that patients don't have to basically have a wire sticking out of their breast like we see here in the moments before surgery. Next slide. So some people started to sort of skirt this issue by using intraoperative ultrasound, which is a way for us not to have to use one of these wires. Next slide. We also developed seeds, which is sort of similar to a wire in that it targets the area. It is a seed that is placed by a radiologist close to the area, the cancer or any other abnormality that may be seen in the breast. Seeds started with radioactive seeds, which are radioactive iodine-125 impregnated titanium seeds that could be implanted 1 to 5 days before surgery. And then we would detect it with an already available gamma probe in the operating room. Obviously, because it's radioactive iodine, there are some regulations that some hospitals want to avoid, and so the market, being the market out there, developed a number of solutions to this. And here at Kings County, starting last year, we have started using the localizer wire-free guidance system, which is a radio frequency identification tag that can be placed at any point FDA approved prior to the moment of surgery. Each tag is a unique identification number, and basically what it does, it allows for the surgeon to start early, start on the morning of surgery, It also allows for the patient not to have to undergo a wire placement on the morning of surgery, and they don't have to have a wire, again, sticking out of their breast. The workflow of using a seed, like we are using here at Kings County now, is that the tags are placed by radiology, they're extracted by the surgeon, and then they are disposed of by pathology. Next slide. So this is a mammogram of a tag that was used to localize an area in the right breast of this patient. Again, we can see that in 2 views. And again, this has helped us in terms of scheduling. We can localize these areas, introduce those tags or seeds days before surgery. And then after we remove the area, we'll take a picture of that specimen, make sure that both the tag and the biopsy clip have been removed. Next slide. So in terms of the number of patients that have been receiving lumpectomies as part of their breast cancer care, it's important for us to assess the margins, or like I said earlier, the borders of these tissues that we remove. The rationale to this is that most women nowadays still choose breast conserving surgery over mastectomy, and unfortunately as much as 20 to 30% of margins end up being positive microscopically, requiring a second operation for the clearance of these margins, right? It is important for us to intraoperatively assess the margins. Go back, please. So that we can avoid subsequent trips to the operating room. Important for us to confirm extraction of the wire or seed and the biopsy clip. And so at Kings County, we are using intraoperative specimen imaging and using margin assessment with margin probe, and I'll explain both in a second. So basically, intraoperative specimen imaging refers to having a machine that takes an x-ray or a picture of the specimen inside of the operating room, and that allows for instant confirmation of the extraction of the lesion, of the wire or non-wire, and the clip, again without the specimen having to leave the operating room. It allows also for faster completion of the operation. We can finish the cases much quicker, and we can always communicate with the radiologist because they would have access to these films. Next slide. Sort of in the same vein that we talk about margins, we are now here at Kings County using the margin probe system, which is a system that uses electromagnetic waves to identify possibly cancerous tissue in the tissue that was removed. And it helps us intraoperatively try and sort of guesstimate whether additional tissue needs to be extracted. The use of this machine has been shown to reduce re-excision rates by as much as 60%, and we are very happy to be able to offer patients that here at Kings County. Next slide. So that's sort of the data and the update part of my talk. I did want to invite everyone to the Comprehensive Breast Center. I'm very proud of the work that the entire team has been doing. The Comprehensive Breast Center, like I said, opened up its doors back in May of this year with the goal or the mission to offer all of the disciplines that require good breast cancer care and sort of quote unquote all under one roof. The point of the Comprehensive Breast Center is that it gives patients, again, a quote unquote one-stop shop approach to breast cancer, where a patient is able to come in, get their imaging, get their surgery if they need it, all the way out to their follow-up for their breast cancer. Next slide. So what we are trying to do here at the Comprehensive Breast Center, like I said, is offer integrated multidisciplinary evidence-based care for the evaluation and management of not only breast cancer, but also benign breast conditions. We offer, in conjunction with Dr. Patel and the breast imaging division, screening and diagnostic imaging, which includes mammography, ultrasound, and MRI. We offer, obviously, breast surgery, breast oncologic surgery, and we offer, along with our plastic surgery colleagues, reconstructive surgery as well. Once tumors are removed, our pathologists help us perform adequate tissue evaluation. And then if patients require systemic or adjuvant therapy, our colleagues over at the Cancer Center are able to offer chemotherapy or endocrine therapy. Some patients will require radiation therapy to treat their breast cancer, and this is under Dr. Nochetti here in Kings County. Also, within the Comprehensive Breast Center, we are now able to offer a survivorship program. After a patient sort of has their 5-year anniversary of being cancer-free, we graduate them to the survivorship program, which means the chances of the cancer coming back are lower, never zero, unfortunately, but much lower. And we don't want to sort of sever our ties with these patients, so we keep bringing them back at least once a year and making sure that all their imaging is done and everything else. We're also ramping up our genetics program. Hopefully, we'll be able to hire a genetic counselor soon that will see patients in the Comprehensive Breast Center. And again, like I said earlier, as more and more patients are undergoing genetic testing, that would be an essential thing to have here in the Comprehensive Breast Center. The breast center will also offer nutritional guidance, behavioral health support, and support services along with our friends at social work. Next slide. So like I said, the breast center opened back in May. It is in the S building on the 2nd floor on hallway 3. It's a little bit hard to get, but we now have a big old sign out there that shows that we are there in order for us to take good care of our patients. Next slide. And the ultimate goal with the creation of the Comprehensive Breast Center is to get obviously national accreditation, and this is done through a program from the American College of Surgeons called the National Accreditation Program for Breast Centers. We are hoping to be number 38 in the state of New York. And again, the point of this program or this accreditation is that it not only provides structure and the resources for us to develop good breast cancer care, but also it makes sure that quality is always maintained at the highest level. So again, we will hopefully be applying for this within the next year or so. And we're very happy to be able to offer this to our patients in our community. Next slide. So again, our information is here. Our telephone number at the Comprehensive Breast Center is 718-245-2994. You can also email us at Kings County Breast Center at nychhc.org. And again, like I said, we are there open from Monday through Friday, open and willing to take care of your patients, take care of the community. And like I said, not only breast cancer, not only breast cancer, but any breast condition that a patient might have. So again, thank you all for joining me. We look forward to seeing you, your patients, for referring doctors, and obviously the patients and their families here at the Comprehensive Breast Center in New York City Health Hospitals, Kings County. Thank you.
All right. Well, great.
Oh, great.
That